Clerk, the next bill.
House Bill 2611 relating to continuing education for healthcare professionals and declaring an emergency.
Question now arises upon third reading and final passage of House Bill 2611A. Representative Keny-Guyer.
Thank you, Mr. Speaker. House Bill 2611A is about cultural competency. Oregon's increasingly diverse population has differing health needs and, unfortunately, great disparities in health outcomes. Research over the last several decades has shown that understanding cultural differences leads to far better health outcomes. As we incorporate patient-centered care in our efforts to provide higher quality care at a lower cost, healthcare providers need tools to understand their patients' cultural context and to design health behavior strategies that will work for them. Over the last 2 years, Oregon Health Authority's Office of Health Equity has done excellent work in conjunction with health licensing boards and community groups to research the most effective training in cultural competence. House Bill 2611A builds on this work by establishing a more formal system for cultural competence training of health professionals in Oregon. It provides that licensing boards in health-related fields adopt rules in collaboration with Oregon Health Authority to determine which training will count towards optional continuing education for their licensees and to track documentation in such training. It also allows boards to require this continuing education for their licensees if they determine that it's needed in their profession. 2611 also allows public universities and community colleges to decide whether licensed healthcare providers working in their health clinics must take training in culturally competent care geared specifically for the college population. After working for compromises with some of the boards and my colleagues here in the House, we've had no testimony in opposition, full support from the many parties who weighed in. There are 2 letters of support on your desk from Oregon Medical Association and Oregon Nurses Association, as well as 15 letters of support in OLIS, and many more endorsers also on a letter on your desk. 2611 will help equip healthcare professionals to effectively deliver care for a diverse community and eliminate barriers for achieving the best health possible. I urge your aye support.
Further discussion, Representative Gallegos.
Thank you, Mr. Speaker. Colleagues, this is a jobs bill. This is a workforce development bill. And, you know, while I was hitting the doors last summer, my message was pretty simple, that we need a healthy and educated workforce in order for business to thrive, for our communities to prosper. And this bill will help us to secure and maintain a healthy workforce that is good for business. So other than just being good for social justice and morally right, etc., please understand that this is a bill that will help the economy. Research has shown us that cultural competence, including the cultural variable in our health care, simply is economically sound in the long run. So I want to share with you maybe an example of what this cultural competency business gets at. A few years ago, I sponsored a conference at the University of Portland on death and dying. And our keynote speaker was a Father O'Malley, who was the chaplain at Providence Hospital. And Father O'Malley told the story of an elder Hmong who was in the hospital dying, and his family was there and very anxious about dressing him in traditional Hmong costume. And the nursing staff didn't know how to handle it. Luckily, after a lot of red tape and bureaucratic business, the family was able to dress him in this beautiful costume, and he was dressed that way as he passed over. Now the cultural issue is that among Hmongs, they believe that one spends the rest of eternity dressed as however you are when you pass over. Cultural competency. Actually, I chuckle about this because I think about dying in a hospital with one of those hospital gowns on, and spending eternity floating in the clouds with that thing flapping in the back. Not a pretty sight. But seriously, think about cultural competency in other contexts as well. I mean, think about this. This has been 30 years since the concept of cultural competency has been entered the literature, the academic literature. 30 years that we've been talking about this stuff. So, as I mentioned before, my research and other academics have really done considerable research on the notion that cultural competency, and including culture in the healthcare practice, in the diagnosis of healthcare issues, in the planning of healthcare interventions, and in the resolution, all of those things really are enhanced when one considers diversity. And when we talk about cultural competency, we're not just talking about race. We're talking about gender differences, sexual orientation, age differences, any difference that's going to make a difference in that diagnosis, in that helping process. But an example I want to share with you in terms of ethnic differences. For example, African Americans tend to have higher rates of hypertension and heart disease. Native Americans have higher rates of diabetes. Latinos and diabetes is another interesting cultural kind of ailment, in that Mexican ancestry folks tend to be like 3 times as likely to have diabetes than white folks in this country. On the other hand, Cubans and Puerto Ricans, because they have African American genetic backgrounds, are not as likely as Mexicans who have Native American heritage as well. So anyway, that's the kind of thing that I think is important in terms of healthcare, to understand these differences. So again, I just want to close by, again, just mentioning that establishing cultural competency standards in healthcare training is an element needed for improving patient care and healthcare outcomes and reducing healthcare costs for all Oregonians. The idea is that cultural competency will not only help healthcare workers cut
Representative
costs.
Gilliam yields.
And so finally, as good stewards, I encourage you to vote an aye on this. Thank you.
Further discussion, Representative Freeman.
Thank you, Mr. Speaker. And I think we all could have enjoyed going to lunch without the image of the previous speaker in a gown from the hospital. I do have a question of the carrier.
Question the carrier, does she yield?
Great, thank you. And I like the policy behind this bill. Was there any discussion in the committee, in the policy committee, about the cost of providing this competency training?
There was discussion. There's actually a number of different ways that this training can be delivered. There are a lot of classes online that are actually free. There can be mentorships that can be set up. The idea would be that the Oregon Health Authority has been working really hard over the last couple of years to determine what is really evidence-based training that shows good results. And when people do continuing ed, they have to do an evaluation 6 months later. So part of the tracking and documentation of it is to make sure that as people choose to take continuing ed, and the idea is that each of these different licensed professions, so be it midwives or dentists or social workers or doctors or nurses, psychiatrists, that they work with Oregon Health Authority to look at what is the gamut out there of courses, and each of those professions can decide what's appropriate for their particular profession. Right now, it's optional. They would then say to their licensees, here in conjunction with Oregon Health Authority is what we decide is really good, culturally competent care. You decide what's the best for your profession. So it could be any of those range of things. It could be in addition to the continuing ed. If they choose to require it, actually, it could be in addition to the continuing ed they have now, or it might be part of the ethics. It might be in place of other continuing ed. It's really for them to decide what makes their professionals the most competent professionals they can be. They would then look at what the different costs are and weigh, is that worth it to us to require that kind of training? Again, we're not requiring the training. It would be up to the license boards if they choose to make it optional or they choose to require it.
Can I follow up, please?
Further question to Carrie, does she yield?
I do.
She does.
So I think I heard the answer in all that. So the committee decided that there was no fiscal on the bill because that the decision on whether to require it or not would be made through rule by the Oregon Health Authority.
It would be made by rule by each of the different licensed agencies. I don't think there's a lot of cost in that. They do their rulemaking all the time. Of course, that's not a cost that the state would bear. If there was a cost, that would be borne among their licensees, since licensees have to pay for whatever the cost of a licensing board is. For Oregon Health Authority, who would be working in conjunction with them to share with them what they've been finding in terms of best practices, they put no fiscal on it because it's what they do. This is the Oregon Health Authority Office of Health Equity. This is what they consider as part of their daily work, and it's a high priority to them.
Thank you. To the bill, please.
To the bill.
So colleagues, coordinated care organization, that entire chunk of policy we did included the requirement for cultural competency. So our Medicaid population and our coordinated care organizations, this was already part of that. So really what I was trying to figure out was who else? I mean, who else did we forget or who are we including in this bill? And that's why I asked the budget question. For it to be meaningful and be a job creation bill and for people to actually get the training that this bill seeks out, somebody's going to pay for it. It's not free. It takes time away from being a healthcare provider. It takes time for an instructor. All those things cost money. We had a similar bill to this last session, and I got up and spoke about the cost, and really it needs to be run through Ways and Means so we know what it is we're doing, what it's going to cost, and we should fund it. My entire point last time was that if we're going to do this as a body, we should figure out a way to pay for it. Instead of allowing rule and boards and providers to pay for this, if it's that important to us, we should figure out a way to fund it. And just as I did last time, I'm going to state, because we're not funding it with real dollars to make it happen, I will be a no. Thank you.
Further discussion, Representative Parrish.
Thank you. Colleagues, as somebody of Middle Eastern descent, Marfan syndrome runs in my family. It's a kind of an unknown healthcare problem, and but it can affect folks of Middle Eastern descent. This bill would not tell my doctor that Marfan syndrome runs in my family. This bill, when people came and proposed this bill to us in 2011, the proponents of the bill came and said, if we have this bill, my uncle, grandfather, whoever would have gotten a cancer screening on time. If the goal of this bill is to really connect healthcare practitioners to the types of care that people need based on gender, culture, race, orientation, then this actually doesn't get us there. And I'm really glad to see that the mandate piece of requiring 140,000 people to stop their day at some point in any given year and go take this as continuing education. I'm glad the mandate piece is gone, because this bill doesn't do the piece that I think the proponents really want, the piece that I think I'd like to see happen, that we get customized medicine that is based on who we are and where we're at in our lives and what our backgrounds is, but a bill that talks about cultural sensitivity, cultural competency, and particularly given that the healthcare fields actually do a whole lot of this right now as part of their course of study. This bill doesn't get us there. What we need to be asking our state to do is to put together a database that somebody can go in and search that says Julie Parrish is a 38-year-old woman of Middle Eastern descent and she's had 3 kids. What are her health outcomes? And that is available for everybody. That's cultural competent medicine. That is customized medicine. A class, asking our healthcare practitioners to go and take a class isn't going to get somebody who's of Filipino descent a cancer screening 5 years before somebody who's of Caucasian descent. I know that's what the proponents of the bill want this to do, but that doesn't do it. I'm going to support the bill because we've taken the mandate piece out, but I hope that as we continue to have this conversation about cultural specific medicine, about mass customization of medicine for individuals, that we start to be data driven and make sure that doctors and practitioners actually have the data they need to deliver us that health care, because this bill doesn't do that. Thank you.
Further discussion, Representative Greenlick.
Thank you, Mr. Speaker. To the bill.
The bill.
This bill is really a pretty simple bill. All health professionals take continuing education. And all this bill does is essentially ask the boards to decide whether a piece of the continuing education that their licensees are going to take should include cultural competence. My colleague from House District 58 and I were having a conversation, a couple of old medical sociologists talking about things, and part of the issue is we were talking about the name cultural competence. Are we going to treat people, are we going to train people to be really competent to deal with every single culture? No, but what we would hope that we can achieve is to deal with cultural sensitivity. That means to teach professionals to be sensitive to the fact that there are cultural issues in the delivery of healthcare, and to be more attuned to those cultural differences so they can begin to learn and can begin to ask questions to deal with their patients in a more sensitive way. Exactly as dealing with the Hmong patient. So all this bill does is that it alerts the licensing agencies to take some care to deciding what part of their continuing education their licensees ought to be related to helping them become more culturally sensitive. Thank you, Mr. Speaker.
Further discussion? Seeing none, Representative Keny-Guyer, do you wish to close?
Yes, I do. Thank you, Mr. Speaker. So, colleagues, I can well appreciate that this bill is not the be-all and end-all. It really is building on the work that's been done in this area, many decades of work that Representative from Hillsborough, Forest Grove has been engaged in for decades. And it gets at trying to increase knowledge, skills, and attitudes about cultural sensitivity. So in some cases, there could be a wide variety of courses. There's not a cookie cutter approach to this. If a healthcare provider is working with a Russian population or a Latino population, they may choose to take something that delves more into that. Or it may be just more sensitivity about what are the kind of questions that you can ask if you're trying to help someone decrease obesity and get out there and exercise. How might that fit? What are the kinds of questions that you can ask about their culture? So when patients walk in the room, they're not just a pulse and what's your blood pressure, what's your weight and your height. They're much more than that. And if we're ever going to be able to really reach out to patients and make sure that the health strategies and the health behavior that we want to encourage fits in their culture, then this is really an essential piece. What I do want to recognize, I see some people in the audience here who are part of the Oregon Health Equity Alliance, most notably Urban League, Oregon Action, APANO. A lot of groups have worked on this with healthcare providers, with the licensing boards, to say, here are the communities we represent, and the providers are representing the provider community. How can we really equip the provider community to really meet the needs of the community? This has been a fantastic collaboration over the last couple of years to really determine how can we most effectively, in a very short amount of time, help providers have the tools they need to address needs in this population. So again, I urge your aye vote. Thank you very much.
Those who are of the opinion the bill should pass will vote aye. Those opposed, no. The clerk will open the voting system. Representative Huffman, how do you vote? Huffman votes aye. Representative Thatcher, how do you vote? Thatcher votes, was that no? No. House Bill 2611, having received the constitutional majority, is declared passed.